Tansei, from unceded and unsurrendered territory of the Algonquin peoples. It is wonderful to be broadcasting live, and thank you to everybody listening on the radio and welcoming us into your nations across Turtle Island. Welcome to the First Nations Health Managers Association Town Hall, where we talk about COVID-19, tools, supports, and other relevant information with respect to this pandemic. And I know it's March 279th. Does that sound about right, folks? It's just the march that'll never end, I swear. But we have a lot of information for you today. I do want to say a quick thank you to our guests who have joined us today. We also want to thank Indigenous Health Today and the folks at Nation Talk for making this possible for all of us. And a big shout out to NCI. I love chatting with the morning show every Thursday, where we get an opportunity to talk about the upcoming town hall. And for those that don't listen, which you should be, but you should know that Davey and I from NCI Morning Show have decided to enter a new business, and we're going to be beating bingo dabber holders. So just a little joke there for all of you guys to kick off our hour together. All right, well, if you have questions, folks, you know the drill. Send those questions. We'll read them on air, if not today for these panelists, and we'll come back in January and get some responses for you. But send those questions to fnhmay@ihtoday.ca. Another note for you before we go over to Linda is that this is our last town hall before the Christmas break. And we'll have some closing comments on that, but look forward to seeing you all next year on January the 14th. Okay, let's jump into this. We do have an update from Indigenous Services Canada, like we do every week, and it is a pleasure to welcome Linda to this discussion. Linda Pillsworth from Indigenous Services Canada, let's hear from you right off the top. Welcome, Linda.
Great. Thank you so much, Marian. And thank you very much for inviting me to this very important place. I'm joining you here from the beautiful BC Coast Salish territory. And I'm here to speak about environmental public health. My background is as a certified public health inspector. I have had the great opportunity to be in this field for 17 years, majority of it which has been with First Nations Health, originally with FNIB in British Columbia, and assisting in the transformation to the BC First Nations Health Authority. Until recently, I'm back with Indigenous Services Canada. So thank you for having me. What is environmental public health, you might question? So these are really the conditions in the environment, both natural and human built, that can affect a person's ability to achieve and maintain good health. So really, we identify and prevent environmental public health risks, those in the natural and built environments, and those that might affect our health. And we deliver this type of a service through environmental public health officers, who many of you may know either through direct service by First Nations Inuit Health Branch, or as many, about 40% of the staff have been transferred to individual First Nations or tribal councils and organizations. So environmental public health officers, our role is to, through inspections, monitoring, surveillance, advice, guidance, education, we support communities through recommendations to help communities prevent and manage those public health risks that can be found in the environment. So through analyzing data, gathering observations, really our role is around health protection and promotion in communities. An important piece of this is also training and raising awareness in communities about what those risks might be, and what are some basic steps that people can take to protect themselves and their families, and what is within their control, and what might be aspects that community leadership and others have roles with. So we very much do this work in collaboration with communities, which is a fantastic and very important way to carry out our work. A bit more background on environmental public health officers. These are recognized public health professionals with discipline specific core competencies. So there's only a handful of institutions in Canada that provide this training and certify the officers. And there are also national training requirements for First Nations Inuit Health Branch environmental public health officers. So you may be familiar with public health inspector roles in municipalities and other and provinces who carry out a regulatory function. However, our environmental public health staff are very much a partner to communities. So we work in conjunction with communities with a very much more expanded scope of work because we are not limited by legislation, and we really work to address the priorities and concerns of communities specifically. Through this work, it is not just ourselves that do this work. Communities leaders, administration are essential to the work, and in terms of mitigating health risks. And as well, we work across many partners and stakeholders across not only the sectors within communities, so this could include is not only, of course, the health staff, but also the infrastructure and public works, housing administration, lands and economic development in many cases, and even across provincial and other federal families around environment, health, and other aspects. So very much a collaborative and intersectoral approach is what is needed in our work because our work crosses so many different types of issues. And so how do we work? Really, we are grounded in trust and relationships. It is foundational that we become familiar with the communities and understand what those concerns and priorities are. We have a longstanding program that has been delivered by First Nations Inuit Health Branch, and so we build upon this relationship and trust. And I mentioned previously that the province typically carries out their work based on legislation. However, although we have core programs and services, we are really guided by communities, community-identified prioritized activities through joint work plans with communities. And we very much work across those disciplines in the community and within the provincial health system. In terms of what types of activities we carry out, very much health assessments are part of it. So through inspecting public health facilities, investigations, sampling and monitoring. Again, I mentioned the education and awareness is very, very key to create awareness of the types of risks and the practical ways in which everyone as an individual and how communities can foster and create health supporting environments. Surveillance is also a key piece. This is an important piece around drinking water and other types of data that might inform whether a public health risk exists or not. In looking at what core program areas we cover, you might think of some of the very obvious aspects, such as drinking water. We support communities in community-based drinking water monitoring, understanding the water quality and whether they meet health and safety standards. But we also work at the front end of many of those infrastructure aspects. So reviewing plans before infrastructure is put in place to make sure that all opportunities are put in place to identify and prevent any future risks from happening, and focusing on the importance of operations and maintenance, multi-barrier approaches to safety of drinking water. So in this realm, we very much work closely with the community-based drinking water quality monitors that are in communities, as well as water treatment plant operators in communities that take a very, very important role in taking care of drinking water in the community. Housing is our second largest program area. And through this, in request inspections, often residents are concerned around air quality, safety of their homes. And so our role in a housing inspection is really to identify what are the health and safety aspects of the condition of the home and what might be needed to mitigate some of those issues. Working with housing administrators to look at where they might prioritize and, what are some key issues that are being observed. And again, providing that education, prevention, and awareness around, maintenance and how to minimize public health risks in the home. Facility inspections are key, and these are public places where community members and even other individuals outside of the community may have access to on-reserve facilities. So these might be health facilities, schools, daycares, long-term care facilities, recreational facilities. And again, through this, we inspect and identify and find all ways in which risks can be minimized through inspection and education. Our fourth program area, again, is very important, and it's a traditional core program of public health inspection is food safety, whether those are restaurants or facilities or large gathering events where there's a significant amount of public food service. These are important because of the potential for foodborne illness outbreaks. And so not only does our work help to minimize and prevent outbreaks, but should there be illnesses occurring, we would also be providing outbreak investigation to that. When I reflect back on my training and the traditional roles of public health inspection, this is an area where working with Indigenous communities is so important because of the unique aspects of traditional foods, the historical traditional food practices, and just that wonderful connection that there is with food in this area. Wastewater, again, sewage can be a significant source of disease. And so as a sanitarian role, which public health inspection has generated from minimizing the potential for contact with illness-causing substances like sewage is so important. So ensuring that sewage systems are properly built and operated to ensure that there is no contact and ability for disease transmission is an important aspect. Solid waste is a smaller area where we work on through landfill sites and really focusing on what are those imminent public health risks that might be created through potentially from the necessities in the past, such as burning and open access landfills, and working with communities to identify what those risks might be and potential ways to manage and mitigate those risks. Environmental communicable disease control is a very important area. Again, it's the foundation of public health and minimizing disease transmission around food, water, and vectors such as mosquitoes, ticks. You might all be familiar with West Nile virus and Lyme disease. So those are all areas that we very frequently work within. Through any sort of foodborne or waterborne illness, we are integrally involved in supporting communities on identifying where those illnesses are coming from, following up with cases, and investigating the source of that outbreak. And of course, providing recommendations and education around minimizing. Finally, emergency preparedness and response. Of course, emergencies are not new to many of us, and this pandemic is definitely creating a new layer of emergency onto everyone. And this is an area where we work closely with communities, whether it's a flood, a fire, or other type of emergency, to really look at what are those essential infrastructure aspects, the impacts to housing, water, sewage systems, and also looking at during the response phases, should there be temporary accommodations and reception sites needed, ensuring that those facilities are established and operating in a way that it won't create new health risks. So very much public health risk mitigation through all of these types of emergency scenarios are extremely important. In terms of environmental public health and the COVID-19 response, we've had a very integral role into this and working very closely with communities. because disease prevention and risk mitigation is central to our activities, we have a strong role in disease response, and as well as emergency response has assisted in bringing that capacity to not only to FNIB, emergency operations centers, providing that liaison role to provincial operations centers, and ensuring that there's connection across various different aspects around infrastructure, isolation centers, temporary facilities, and very much as communities began to reopen in the summer, supporting communities around what are those public health measures and needs that need to be implemented to ensure safe operation of community services and facilities. We very much provided some technical specialist role, which is very region specific. In some cases, some regions have very strong IT and other technical capacity that can support communities. And throughout all aspects of the response, we've been providing environmental public health guidance. We've nationally also supported in the development of over 40 different types of guidance documents, and similar roles and functions are happening at the regional level, very much close to communities in helping apply what those public health measures and guidance is. In terms of operations, implementing all the prevention measures is so important, whether that is at the surge infrastructure level with high-risk facilities such as long-term care facilities, as well as reopening. We very much, want communities to be supported in how should these measures be applied, practically speaking and realistically speaking, in each community's different situation that they might be faced with. Additionally, training and education has been a strong and important key piece around infection control and prevention, cleaning and disinfection practices, as well as general sanitation and personal protective equipment. And as you all know, those are very key fundamental public health measures that need to be in place and ongoing throughout this pandemic as things move forward. In my slides, I did have a couple notations around how we are embedded in some of the incident command structures. So depending on the region, we have had roles including the incident command center, the operations leads, technical specialist, information specialists, and e-health specialists. So there's very much a strong embedded role with the incident response, and such that as issues arise, whether they are with facilities or other aspects, they can be integrated and embedded in the response so that there's effective community support provided through that. It's definitely, as in my public health career, I didn't think I would be participating in such an important part of our history, but I'm very grateful that I'm in this role to be supporting communities through this, and definitely it is a challenge. And I'll just put one plug in here about our public health as a career, environmental public health specifically. It's been very rewarding to be in this role in terms of the relationships. The role is very independent. Every day is new. The emerging issues, whether it's climate change related, other experiences on the West Coast, things like Vibrio cholera, very, very many different types of issues that come up. And as well, it's been a very progressive profession, starting from the traditional roles that, historically have been food, water, sewage, are now evolving into very much more of a, and I know this will resonate to all of you, is a much more holistic approach to looking at health, because we are looking more towards how do we create healthy environments that are supportive of communities and minimize and prevent risks while promoting healthy individuals and healthy lifestyles. So this is a very exciting and rewarding profession to be in. So I'd encourage you or any of your staff, if they are interested in this role and working directly with communities, to speak with an environmental public health officer, as well as seek out our website, professional website, which is www.ciphi.ca for more information about the career. So very much, it is exciting work. Our role is very different day to day, whether it's working with emergencies or traditional foods, it's such a rewarding work. So thank you very much, and look forward to any questions.
Great. Thank you so much, Linda, and for putting in that plug for emerging health careers for any of our young listeners who are wanting to get into public health as a career. We really appreciate that as well. So, Linda, I will give you a heads up that our audiences will probably want to know what the COVID stats are in First Nation populations. So I will come back to you when we go to the inbox a little later in the show. All right. So again, just a reminder to all of our listeners, to all of our viewers, if you do have a question, please send those in to fnhma@ihtoday.ca. And I do want to do a little shout out to one of our viewers right now. Hello, Curtis. I know you're watching, and one of the staff did, transmit in my ear saying, say hello to Curtis Morin. So hi, thanks for watching and getting your COVID information that's relevant, timely, and accessible here on the FNHMA Town Halls. All right, so I can't answer Jordan Stone on where you can purchase those bingo dabbers because we haven't done it yet, and we did not trademark this either. So no request for bingo dabbers that are beaded. You got to laugh, right? We're talking about a pandemic and such heavy topics that every once in a while you got to bring in a bingo comment and a joke. So now let's get back to serious business. We want to welcome Dr. James Brooks, who is joining us from the Public Health Agency of Canada. Dr. Brooks, please share with us what has been keeping you busy and some information about your role in infectious diseases. That was a hard thing to say. Sorry, Dr. Brooks. Welcome to the FNHMA Town Hall.
Thank you very much, Marion, and thank you for the invitation and the opportunity to present today. And I'd like to begin by acknowledging that that Canada is the homeland of First Nation, Inuit, and Métis people, and that today I'm coming to you virtually from the unceded traditional territory of the Algonquin people. So Marion asked me to come and talk to you today about COVID testing in wastewater. So this is something that's been occupying my time for the past 6 months, and so I'd like to take the opportunity to explain what that means or what that can mean for your communities. So let me begin by saying that, just orienting you, I'm going to tell you a little bit about the background of wastewater testing, and then I'm going to tell you a little bit about what the Public Health Agency has been doing. And there's many different groups that are doing testing in the wastewater, and some may be already going on in your communities, as there are both local authorities and universities that are doing this alongside us. And then I'm going to just talk a little bit about where I think there are some specific applications in Indigenous communities for wastewater testing. So, let me first of all just explain what wastewater is, and I think it's what you think it is. Wastewater is the stuff that flows out of your house, and it's the collection of what is flushed down the toilet, or what enters the shower drain or the sink drain coming out of the dishwasher. And this can either go into a holding tank and then it gets trucked away. It can go into a septic bed in your backyard, or it can go to a wastewater treatment facility where it may go into a lagoon, or it gets treated and then sent back into the watershed. And so you can imagine that if an infection can go enter into your is it in your bowels or in your digestive system, that the evidence of that infection will also be in the wastewater. And so while I'm talking to you about this, the application or thinking about testing for COVID-19 in wastewater is relatively new. People testing for infectious diseases and other things in wastewater has been going on for quite some time. One of the diseases that we're fortunate in Canada not to worry about is polio. And the reason that we don't worry about polio that in Canada now is because of vaccines. But in areas where there is still polio, one of the ways that you can find out if there has been enough vaccine in a neighborhood or a village or a city is you can actually measure for the live polio virus in the sewage or the wastewater. And this has been done in many countries around the world. And so you can imagine if you went to an area where you had a vaccination program, you would take out some of the wastewater and find out if you can find the polio virus. If you can't find the polio virus, then you go, okay, there's enough vaccination in that area. You go to another area and do the same thing, and you still find live polio virus in there. And what that means is that the people in the community are not vaccinated adequately. And so it's very useful for guiding public health programs. Here in Canada, Statistics Canada has conducted a study called the Canadian Wastewater Survey. And one of the things that they looked at was illicit drug use. And so it turns out that if you're a person who uses opiates or a person who uses cocaine, once you've taken those drugs, the metabolites of those drugs go into either your urine or into your stool, and then they go into the wastewater. So this can be measured at the wastewater treatment plant, and this has been done in Canada looking at the opiate use and cocaine use in 5 large cities. And you can see differences, whereas the cocaine use is fairly even across these cities that are measured, which would be Halifax, Montreal, Toronto, Edmonton, Vancouver. You can see that there is quite a difference in opiate use. And this is important for public health and trying to understand what are the targets for helping people who use drugs. And you can imagine in a situation where there's lots of opiate use, you want to ensure that there are lots of naloxone kits available to people, and you want to ensure that there are sufficient treatment facilities available for people who choose to no longer use these drugs. And all of this information can be found out from one single sample in the wastewater versus carrying out surveys in that city, which may be inaccurate, or relying on inaccurate information that may be coming from the police force. And another area, it's described to me this week as a silent epidemic, is antimicrobial resistance. And what that means that if you get an infection, a strep throat or a pneumonia caused by bacteria, and you would normally take antibiotics to treat those infections, sometimes the bacteria that cause those infections can become resistant to the antibiotics, and they will no longer work. And I say it's silent because it's not obvious to people unless you do become sick and go into hospital and are infected with one of these resistant organisms. And the rate of resistance has been increasing in many different places in the world. And one of the ways that you can monitor for the resistance is you can take a sample from the wastewater. And you take that sample and then you use special chemistry and you figure out what is the pattern of resistance that you're seeing in that wastewater. And as a result of that, you can provide that information back to the health authorities in that city, describe what you're seeing and say, hey, one of the things that may be causing this resistance is you're using too many antibiotics. And then you can figure out strategies of how to reduce the amount of antibiotics that are being used inappropriately, so that when somebody does need antibiotic treatment, you know that it will work. And all of that information can come from a single sample in wastewater. So giving you the background of where you can use testing of wastewater to answer different questions, we'll now talk about how you can how you can test for COVID in wastewater. So the first question you might want to ask is, hey, I know that COVID causes pneumonia, but how does it get into your digestive system? Well, as it turns out, the same receptors that are in your lungs that attract the virus are also in your digestive system. So most people will have the virus that causes COVID-19 in their digestive system. So if it's in their digestive system, when they go to the toilet, it's going to enter the wastewater. And the other question that you might want to ask is, how often does this happen? And it's when people have looked, if you can find it in the sputum, which is the way that we do the diagnostic tests to determine if somebody has COVID, then you're also going to find it in the digestive system and therefore going into the wastewater. Another question you might ask, you say, okay, I can understand it's going into the wastewater, but doesn't it just die and maybe you can't find it anymore? Well, it's probably true that it's no longer alive by the time it hits the wastewater treatment plant, so it's not very likely to cause people infections. But one of the things is that you can still find evidence of the virus, and you can find its chromosome. And we have tests that we can measure the amount of virus in the wastewater by looking for evidence of the chromosome. And so it's quite durable, and we can find it for a week or 2 weeks without any difficulty in the water system. So certainly it's going to live long enough from when you flush the toilet until it reaches the sewage treatment plant. And I think one of the things that is most interesting about testing for COVID in the wastewater is, if you imagine taking one sample from a community of 20,000 people, that means you can test one single sample and get the results of the COVID status of those 20,000 people. So if there is no COVID in that community, your test will be negative. If there is some COVID in that community, you'll be able to say whether there is a small amount, a medium amount, or a large amount. And so in that case, you have one test replacing 20 tests. And with that information, you can go and public health can decide, hey, everything is working fine, or they can say this is an increase from what we saw last week when we did the same test, and say we're going to have to increase masking, we're going to have to increase message about washing hands, and we're going to have to make the size of people's bubbles smaller. The other part of looking for the virus in the wastewater is it will test people. It will tell whether there's COVID in the community, independent of whether the people in the community go to get tested. And so why would people not go to get tested? Lots of reasons. But number one, they might have a COVID infection that they don't know. It's what we call asymptomatic. So they don't feel sick, even though they have COVID. Another reason is that people can shed lots of virus even before they feel sick. We call that pre-symptomatic. So you're able to transmit the virus, but you don't yet know that you're sick. And then another thing is that some people don't want to go get tested because of stigma that's associated with testing and having a positive result. So those people might not get tested, and if they don't get tested, then they don't get picked up by public health. But if you're looking in the wastewater, everybody poops, so you're going to find the COVID in the wastewater. And when people have looked at this, they've found that it maps pretty closely to what they're seeing in the community. So, as I said, it will tell you whether you have a small, medium, or large amount of large number of people in the community infected. You can use it, the differences, if you go from having a medium amount in the community to a large amount of community in the community that you're measuring using the wastewater, that probably reflects a large number of people becoming infected. So where would you use it? And I'm going to give you a couple of examples. So if there's a long-term care facility where people come in to work, and there's no COVID in that institution, you'd want to know very, very quickly and very early if a single person has COVID, because people are in an enclosed environment and there may be more than one person in a room, it can spread very, very quickly. So if you're testing the wastewater in that community, or sorry, in that long-term care facility, you'd be able to pick it up very early and then put in measures to prevent the spread to other people. So that's when you're using it as an early warning system. Another time that you might use it is in a community where you have COVID and you've already detected it. You can monitor, perhaps not as frequently as an example I gave before, but you can monitor every week and determine whether the cases are going up or going down. So you can find out, I put in a number of measures to prevent the transmission of COVID. Are they working? And you can also say that maybe they're not working and I'm seeing an increased number of cases. And I think you can also consider, if you're trying to decide among communities about if there's a limited amount of vaccine coming in, then you can say, I see more COVID in this one community than in the other community, similar to the polio example I described earlier. And then you can direct your immunization efforts to the community where you're finding more COVID. So at the Public Health Agency, what we've done is we designed and carried out a study with the Canadian Water Network, which was a way of ensuring that a number of laboratories across the country, and these were mainly in universities, were testing wastewater everywhere from Vancouver to Halifax, that their results were believable and accurate. And what we found out was that any place that we tested, they produced high quality results. And so we're coming to do another one of these studies. And if somebody participates in this study, then you can be assured that you can be confident in the reliability of the results. Another thing that we've done here at the Public Health Agency in partnership with Statistics Canada and Environment Canada is that we're testing about a quarter of the population in Canada by participating in the Canadian Wastewater Survey. So that those are the cities in the cities of Vancouver, Edmonton, Toronto, Montreal, and Halifax. And I have you can't see, but I have a picture here that shows those locations and also shows you the results from a couple of cities. And you can see that we're able to accurately map out the increase in cases that was seen in September and October of this year. And so with that single test, if we're looking at one of the wastewater treatment plants in Toronto, for example, in a single test, we're measuring 1 million people. So instead of having to carry out 1 million individual tests, we can use one test and tell public health, yes, you have an increasing number of cases in your community. And that's and sometimes that information can come ahead of actual cases that are measured in the community. So you can tell public health, hey, we think that you're going to see some more cases over the next few days, and you probably need to improve the steps or enhance those steps that have taken to prevent transmission of COVID. And if you look in the newspaper yesterday, you'll see that we've been involved in COVID-19 testing in Northwest Territories. And in that community, we're testing 3 locations, and both Yellowknife and some smaller communities. And we'd found evidence of COVID in the wastewater when there had been known cases in the community. But this time, we found it in the wastewater and public health wasn't aware of it. And as a result of this, the Chief Public Health Officer, Dr. Cami Gandola, has taken extra measures to find out where those cases are and prevent further spread in her community. So just some what does this mean practically? And I'll finish in the next few minutes here, so Marion doesn't give me the hook and pull me off. Is the place that we've done most of our testing is at wastewater treatment facilities. But does that mean that you can't test in other places? And the answer is no. I think we can test. So we need to find out how well it works, but we could certainly think about testing at lift stations before water goes into lagoons. We can also think about testing water that's collected in sewage trucks from a number of houses in a community. And all of these tests can all be done in a way that you can use the efficiency of the test. And with one test, you can get the results for many households or a community. And when you ask, well, how do you get your sample? There are these machines that are called auto samplers, which take a small sample of wastewater flowing past them every 15 minutes, and you will get a sample that's collected and mixed together that represents the daily flow through that pipe. Or many people that we're working with are using what's called a grab sample, which is just as you would imagine. You take a bucket and you dip it down into the sewage flow and you pull that out and you do your tests on that. And how do you measure it? And all we do is it's exactly the same test that we use when people get tested for COVID off a nasopharyngeal swab, a swab up your nose. We use exactly the same test, but we just put in a couple of steps in between, just to make sure that the other matter that is in sewage is not part of the test that we do, and we're just interested in looking for the COVID-19. I think that we would all like to see a time when this could be done actually at the wastewater treatment site. So we are working hard with the laboratories in the National Microbiome at the Public Health Agency to see about getting testing portable equipment that could then be actually put in place in the wastewater treatment facilities. So I think that's really what I had to tell you about wastewater testing. I think to summarize, I think from this one test, you can get many answers, whether you're looking at for COVID-19 in a community, antimicrobial resistance in a community, or even thinking about using it in places where there's international travel to look as an early warning system for new infections that can be coming to Canada. For COVID, I think you can get an early warning signal, and that's it can happen a few days before you actually detect cases using conventional methods, and that's really important, I think, for close quarter living. And we can also measure how effective the measures are to address the spread of COVID. There are limitations to the testing. I don't think it's really very effective testing in individual households where you can just test the people there. And we don't really know, we can't tell you exactly how many people are infected through testing the wastewater alone, because people will shed the virus long after their infection has passed and they're well again. And there are also challenges of finding the laboratories that need to be close to the sample collection sites in order to make it both efficient and give you the early warning. If it takes a week for your specimen to get to the laboratory, you're going to lose the advantage of the early warning system. And so at the Public Health Agency, we're committed to a wastewater program with a current focus on COVID-19. We're taking a role in making sure that tests done by people other than us at the Public Health Agency are reliable. And we're looking at new ways, and we presented to a number of Indigenous organizations to educate the organizations about what wastewater testing can do for COVID-19 detection. And there are many people you can't see here because it's a slide of a lot of people, but my chief collaborators here are Dr. Chan Mangat, who runs the lab that does this, and his boss, Mike Mulvey, who made all of this happen. My colleague, Abu Mountchili, who is running the program now for me, and my colleague at the National Microbiology Lab, who helps me with all of these things, and that's Dr. Nichani. And with that, I'll thank Marion once again.
Well, thank you, James. It's not an easy dialogue to have over people's lunch breaks. And I giggle, right, because of what the subject matter was. All seriousness, front and center again. Thank you, James. We really appreciate the information. Obviously, another tool in our global fight against coronavirus and this pandemic. Linda, I'm going to come over to you just before going over to the inbox. And you know what, James, don't go away, because as an infectious disease specialist, there might be a couple of questions in here that we can ask of you as well. So, Linda, would you mind just sharing what it looks like in Indigenous nations right now across Turtle Island for our stats? I know that the numbers have increased, especially in Alberta, and one of our guest speakers couldn't join us because of the surge capacity challenges in the hospital that he's practicing in now. So Linda, if you happen to have that information, I'll let you share that with our viewers and listeners.
Absolutely. So what I can share from you, is since our last report, which was December 1st, there's been 1,131 new cases. And since the previous workday that was reported December 7th, there's 135 new cases.
Thank you, Linda. And I will just add a little bit more to that as well. Specifically, we're seeing as of Wednesday, December 9th, associated with First Nations, an increase in numbers. And it's not unlike mainstream health right now. There was 35 positive cases in BC as of our reporting from Indigenous Services Canada the day before, 80 new cases in Alberta, 55 in Saskatchewan, 182 in Manitoba, 1 in Ontario, no new cases in Quebec, and none in Nova Scotia at this time. So I just wanted to share that piece of information with all of our viewers and listeners. And obviously our hearts are with all of our, well, with everybody at this time, but especially those in the prairie provinces. Definitely stay safe right now. I'm going to transition back over to the inbox now. And of course, I did give our panelists a heads up that the topic of concern and of question is vaccinations. When are Indigenous communities in the queue? We know we're identified in the vulnerable population stats for priority. And Linda and James, I'll ask you both, do you have comments on an update or concerns about some of the vaccination challenges that are happening right now? People want to know, when do we get it? Is it safe? What about historical trauma for Indigenous people and vaccinations and trust in the government? Kind of a lot to unpack in a very short window, but I'll put it over to you to comment. And I see Linda, go ahead.
Thank you, Marion. Yes, those are very, very important questions, and very real and serious concerns that people have, and is something that the national group as well as provinces are working on in terms of pulling together all of the information that's needed to ensure that communities and individuals are adequately informed and can make some informed decision making around vaccines. And so the information and products are evolving very, very quickly. And so you may have heard that just yesterday, Pfizer was received approval under Health Canada's vaccine process. And so there will be some initial rollouts next week, which the manufacturer is carrying out through hospitals and key points of vaccinations at this time as a starting point. And so all of the planning in terms of how it rolls out into communities is very much being done jointly with provinces. And as we get awareness around what those allocations are, as there's clarity in terms of how much is coming in, there are a lot of logistical aspects to consider. The vaccines that are the two of them kind of that are first underway will require 2 doses. Between one is 21 days apart and one is 28 days apart. And so there's, of course, logistical challenges around administering that. And so there's a lot of planning underway, and jointly with communities at the regional level, there's close coordination with communities around what those capacities are, and setting up those vaccination clinics. So planning is definitely underway. In terms of the historical trauma, this is something that we're taking very, seriously, because there can be hesitancy. It's new. And with history, it is not something that we want to repeat, and it's an important piece. So again, the communications team is working very closely to establish messaging that is pertinent to Indigenous peoples, and with that awareness, and very much incorporating as much information that can be known around the vaccines, around the process of the approvals is very, very important. So all of those pieces are currently under development, and will be made available. A key piece that is also important is the desire for that communications to be supported through communities. And so working with community leadership to actually share that information from that community viewpoint, and not only relying on our Western world of communicating, such as paper, and really focusing on avenues such as radio, and pertinent Indigenous pathways for communication. So those pieces are important, including in terms of how vaccine is administered, ensuring that there is very strong messaging and information and awareness that comes through well before vaccination clinics takes place, so that there is a comfort level and awareness of the information.
Thank you so much, Linda. And I do just want to give a quick shout out to Bonnie. Bonnie, thanks for sharing the information with respect to what's being tracked for Indigenous peoples on and off reserve in Alberta. And she's just confirming that there are over 3,000 positive cases when we track on and off reserve in First Nations. And I will share with you that this is a dashboard that you can look at if you so choose to take a peek. I'm seeing a dashboard from afnigc.ca, and it's COVID-19 in First Nations people in all of Alberta, and the exact number is 3,094. Now, we're just around the corner in getting a number of other vaccines ready for a probable approval from what we're hearing in the media. What does this mean for us in terms of, that first vaccine, the second vaccine, and really a very tough question, I think, and maybe James, you can digest some of the science around this. There is a comment about there being a lot of misinformation about the science on the Pfizer and Moderna vaccines that include that these vaccines alter or meddle with our DNA. Are you able to explain in layman terms how the vaccines work, and what is an mRNA? I don't know that acronym myself, and now I know we're getting technical. James, is this a fair question for you?
For you, Marion, yes. So it's
for Margaret.
So yes, Margaret. So these are a new class of vaccines, and most of the vaccines that we are used to are either they have either the protein, which is part of the building blocks of a virus or a bacteria, or they actually have the virus or the bacteria that has been chemically killed, and that's in that component, that's in the vaccine. So the idea there is when you give somebody the vaccine, you're giving them essentially the virus or the bacteria, and then the body can mount an immune response to the virus itself. And but of course, because it's not live, it won't make you sick. Now, in this case of the new class of vaccines, they're called they're mRNA, which means messenger RNA, ribonucleic acid. And what RNA is so we sort of step back into some basic biology. From our chromosomes, the chromosomes are like the instruction book on how to build you, right? And your chromosome is different than my chromosome. It's almost identical except for tiny little pieces of it, and that makes us different from one another. But that chromosome then is, in order to actually make those building blocks, the proteins that make us up, things like hair, or the parts that make up your skin, or make a heart muscle, or any of those other things, it goes through an intermediate step, and what's known as the DNA, the chromosome, gets converted to RNA, and the RNA provides the instructions to make those building blocks, the protein. Okay, so now that we understand what role RNA plays in it, we can go back to the vaccine. So what they've done in those vaccines, they have chemically, so it's nothing to do with the virus, but chemically manufactured the RNA with the instruction, they give the instructions on how to make that building block of the virus, but only one part of the virus. So it's not enough to make the whole virus. So when you get that injection, that vaccine, what happens is the body goes, hey, this is just a set of instructions for making a certain building block. And it just happens this time, that building block is only part of the protein. Once that protein has been made, because in our bodies, as I've told you, that's how the human body is built. We always have those messages around. After those messages have been read, they get destroyed. So all that the body is left with is a building block or a protein, a single protein from that virus that it mounts an immune response to. And so the RNA itself is then destroyed and does not go into your chromosome. So that's one of what we call a vaccine myth. So hopefully that's a long answer, but hopefully it made sense.
Thanks, James, and don't go anywhere. There's a couple of more questions regarding the vaccine, and I guess, and we have a very short window, like a minute or two, James, just to respond. But how soon after vaccinations begin will things get back to whatever normal is? And that's an air quote for our radio listeners, normal.
Yeah, so if I knew the answer to that question, I'd get really rich off sports betting, because it's a prediction into the future with a lot of unknowns. And the other thing is that it's going to take a while, because if tomorrow everybody was vaccinated, then things would be different. But because of the limitations on the manufacturer, not everybody will be vaccinated at the same time. So it's going to take a period of time before everybody is immune. So it will take some time. What I will say, unofficially, this is no officially, that I would predict that next Christmas will be much better than this Christmas.
Speaking of Christmas, James, how are you spending your Christmas? What do we need to know going into this holiday season? Please share your thoughts on, do we just celebrate in our home, or can we go see our cookum and mushums? What does it look like for Christmas this year?
So I think the thing about this Christmas is to keep in mind that you want to enjoy time with your elders for many more Christmases. And people that are most vulnerable to serious outcomes from COVID are people over the age of, I think the risk starts to go up at age 60, 70, and especially in people above 80. So our collective responsibility as a society is to prevent infections among those who are most vulnerable. And there is some context for this. So, but certainly in many parts of the country, the rates of COVID-19 infection at the present time are higher than they were during March and April of this year. So I think everybody has to be extremely prudent and aware that the groups, The public health has put in recommendations for different jurisdictions, but what I can say is to expect to have a smaller, it's going to be a smaller Christmas, and I can't. Public health has made those recommendations for individual jurisdictions, but the overriding principle here is we have to protect those who are most vulnerable.
Well, thank you very much, both Linda and James, for being on the FNHMA Town Hall this week. I do want to say a couple of thank yous before we go. And of course, you know what, while you're staying home, while you're staying safe and enjoying the festivities of the season, go back and check out an old town hall if you want to get caught up on some of the ways we can stay well from a holistic sense. And you can also check out APTN, who has rebroadcasting. And I do want to say thank you for the live Facebook partners, Micmac Maliseed News, The Wolf 95.7, Nation News, Element FM in Toronto and Ottawa, NCI FM, Eagle Feather News, Alberta Native News, CJWE, CFWE, CKLB, Co-op Radio, APTN News, and of course on FNHMA. Now, to wish you all a safe, festive, and wonderful holiday season. We do want to welcome you back on January 14th in the new year, where we'll have a whole bunch of new information to share with you regarding COVID-19 and the vaccinations. So until then, stay safe, stay well, and happy holidays. Hi, hi.